So we spent a good amount of time talking about our primary assessment because that's where we have to focus our attention. If we're doing interventions for airway and breathing, circulatory management, this is where now that's where the majority of our time is going to be. Once we've completed that, okay, so we watch that section first. So you go over that. We've done our scene survey. We've done our primary assessment. Treat our life threats. Now, as we move on, what we're essentially doing is we're now making a determination if we have a patient who is, unresponsive, or here I also put altered. So we have a patient who is unable to participate in helping direct us, find, injuries or symptoms. So if somebody is, altered to the point where they're not able to participate, or if they're unresponsive, now what we have to do is a rapid assessment. Okay? So if this is a trauma patient, we're doing a rapid trauma assessment. If it's medical, we'll do a rapid medical. What we're doing here is, since they're unable to participate, now what we're going to do is we're going to start to go body systems. We start at the head. So if we did any interventions in our primary assessment, we're going to reassess those. So if I had an OP, if I needed dissection, or if now I need dissection, we reassess those interventions. I check the neck. If this is a trauma patient, I'm checking for step-ups, I'm checking for tracheal deviation, sizing and applying my cervical collar, right? So making sure that that's on bare skin. I've done the intervention for my neck. Looking at the thorax, right? So now we've done that in our breathing assessment. Now we come back, we reassess. We're looking for, has anything that was wrong with the patient gotten worse? If we did an intervention, is it still working, or do we need to make adjustments to our intervention? So we're going to come back, we do the same assessment that we did for breathing, we're going to do it again. We're going to re-listen to lung sounds. Then we move on to the next body cavity is our abdomen. So this is where now we divide it into 4 quadrants, and we're going to do, our hands. We're going to roll over each quadrant in either a clockwise or counterclockwise fashion. You don't want to jump around, all right? If the patient's unresponsive, you'll start in one quadrant and work your way around. A normal stomach should be soft, non-distended, right? So now we're checking for rigidity. Is it hot to the touch? We're now looking for signs of internal bleeding. If I have an internal bleed, I know that we need to go. Right? We need to get to the hospital. That patient needs surgery. So the purpose of this rapid assessment, this rapid trauma assessment right now that we're doing kind of as an example, is finding and treating other life threats outside of the ABCs. So if I have an internal bleed and they're going to require surgery, this is a life threat. We need to get going. After my abdomen, I come to my pelvis. I'm going to push in and down. So it's a continuous movement, but in first to stabilize. The way the pelvis is shaped, if I have a fracture and I push down on it, if you ever had a pretzel and you snap it, it's going to break into pieces. So if I had a fracture in that pelvic girdle and I push down, I could actually now cause that to separate. And this is where now we could actually cause what we call an open book fracture, where the legs kind of spray out. Remember that the femoral artery runs through that inguinal canal, so when you're checking for your femoral pulses, which you should be doing, it is important to be able to find all these pulse points. There's a big difference between I can't find it and the patient doesn't have one, right? So you want to practice on yourself, finding that inguinal canal, that crease in the groin, and you feel deep in there, and that's where you have that femoral artery. We're checking for those femoral pulses. Especially if we have patients, when we talk about our bleeding and shock, when we get a little further in the program, if I need to apply a tourniquet, I need to know where that is. If I'm going to put a traction, a hair traction splint on, I need to be able to pad over that to not make that anchor, that ischial strap, not make that a tourniquet. So you have to know where this is located. So now we're looking at, we come the pelvic girdle. Now I'm going to, circumferentially, which means feel around, and offset the femurs. And I'm now going to feel if there's, any deformities, if we have any broken bones, if we have any swelling. So we kind of do those major body cavities, and I can do a quick scan to the lower extremities. Do we have any bleeds that need to be addressed? Do we have any broken bones that we need to take care of? I've now done an anterior assessment. Now this is where, if it's a trauma patient, we have, the headman's count. We've got our cervical collar applied. We log roll the patient. We check the posterior, and then we place them on a longboard, and we start to get out. Right? Get loaded up in the ambulance, secure them with straps and head blocks, get them in the back of the ambulance, and we're going to do all of our other interventions on the way to the hospital. If this is a medical patient, we're doing the same thing, but now I'm not so much looking for injuries as I'm looking for signs and symptoms of illnesses. So now I'm looking, when I check, as we come through, is the patient able to swallow? Do they have difficulty swallowing? Is there swelling or cyanosis around the mouth and nose? Do they have, stridor when they breathe? So we go through the same thing. Scene survey, primary assessment, we've already got our general impression of the patient as we walk in, and now we would do that rapid medical assessment. We're looking at body systems, right? Is there anything that we're seeing that's now directing us that the patient maybe is having a heart attack, hypoglycemic patient, a stroke? So now we're looking for these signs and symptoms in the body cavity. So when I check the chest, the heart and lungs live in there. When I check the abdomen, we have lots of different organs. So now, did something rupture? Do we have a bowel that's occluded and now we have an impacted bowel? There's lots of different things here. Do we have a geriatric patient with a UTI? Does the belly feel hot to the touch? So now we're looking for signs and symptoms. The rapid assessment is because they can't answer questions for me. I now have to go and be able to find this information. So you do the same thing, and as you go, if we find something that's concerning, we want to minimize our time on scene and get going. All right? If I have a responsive patient, now I'm going to do a focused assessment. So if I have a trauma patient, I show up to the soccer field and I have somebody sitting on the ground holding their ankle, and as I approach, they're answering all my questions. We've gone through a scene survey, our primary assessment, and now we come in and they're like, my ankle hurts. They're answering everything appropriately. They've denied that there was any hit to the head when they fell. They felt their ankle, pop or turn when they, were, out on the soccer field. I can now do a focused assessment. I've ruled out some of this. They're answering my questions appropriately, so they're not altered. If they were altered, I still have to kind of do this rapid assessment because I couldn't say that there wasn't an injury to the head if they're altered. So we still have to take those precautions. But I have somebody who's very, specific about this is what's hurting me. I can now do a focused, I'm going to start at the ankle, do an assessment there. Once I've done that assessment, maybe I need to splint it, we can do that. Now what I'll do is do a quick assessment. I'll say to the patient, you okay if I just kind of check over real quick, just make sure that nothing else is hurting you. A lot of this now, the assessment, can be done as questions. So no hits to the head, no headaches, nothing like that. Nothing else hurts. When you fell, how did you land? You didn't land on your wrist, nothing else is bothering you. We can do a focused assessment. I have a patient, a medical patient, and they're complaining of chest pain, right? So same thing, you come in and you start to do this focused assessment. They're complaining of chest pain. I've done my scene survey, my primary assessment. We've ruled out, any of those indications. Now I start to come in and I'm asking these questions, right? So we come in and I'm able to do a focused assessment. If we're starting at the chest, we're going to ask questions specific about the chest. Heart and lungs, so I'm asking questions about breathing, right? So we're going to talk about our mnemonics in a second. But now I can do a focused assessment, start to get this information. Now I can put this information together. Once I've done this, these either a rapid assessment or a focused, and then I come back, then what we do for both of these is we come in and we do a detailed assessment. So once I've addressed everything, we've ruled out that we've been able to kind of stabilize this patient, or they're not really a high priority patient, there's no life threats. Now we come in and we can do a detailed assessment, and this is where now we kind of start at the top of the head. If the patient's unresponsive and a trauma patient, this is where now we're palpating. We're looking for battle signs. We're looking for CSF. We're checking, all of the extremities. We're checking CSFs. We're checking all those things for a trauma patient. Medical patient, we're asking questions. Any headaches? Any changes with your vision? Double vision, blurry vision. Any difficulty swallowing? Any fevers? Right? Kind of check and feel. Do they have any swollen lymph nodes? We've talked about breathing in the chest. We're asking about bowel habits. Any trouble going to the bathroom? Any burning when you urinate? Any foul smelling odors? Any blood? Right? Same thing. What was your last bowel movement? Do they have diarrhea? Are they constipated? So now we're looking at, those are important questions for a medical person to ask. It gives us information about what's going on, on the inside. They're able to answer these questions for us. So now we're going through the body systems and we're asking these questions. And so a detailed assessment for a patient who can answer questions for me can go very quickly, but this is a fluid conversation where we're asking questions. So this here is where now we're kind of putting all of this together, okay? So if I start to kind of look at, for those of you that are in my class, you're going to be looking at those sheets. So you're going to follow right along, and you're going to see that this, the way that we put this all together, essentially that whole module is just how do we prioritize looking at that trauma sheet and that medical sheet. For testing, that will be your trauma patient, and you'll have a medical patient. If you were to remove trauma and medical off of those sheets, what you would replace it with on the trauma would be an unresponsive patient, and on the medical would be a responsive patient. So, we don't teach you to the test. We need to get you to pass the test, but we're also looking when you get out that you're going to be a good provider for your patient. So those are meant to be resources for you, not only in school, but also when you get out and you start taking care of patients. It's going to be very specific what you're going to get in a testing scenario, but you're going to go out and you're going to have patients who have multiple, they have a laundry list of symptoms of things that are bothering them. And you need to now be able to prioritize and kind of figure out which ones are kind of being exacerbated by each other, are there medications that are kind of interfering with this. So when we start to look at this, questioning, we've got our mnemonics. We have our OPQRST. The OPQRST, this mnemonic is we're asking about the patient's chief complaint. Why are we here today? Right, so you have a patient who's talking, how's it going? My name's Joe with ABC Ambulance. What seems to be the problem today? How can I help you? Now what they're complaining about, this is what this OPQRST is. So if they're like, oh geez, I'm feeling kind of short of breath. Okay, onset, what were you doing when this started? Right? These are not one and done questions. This mnemonic is to help you get that. But this isn't, when you're learning it, you're kind of robotic. O, onset, what were you doing when this started? And then P, provoke, anything make it better or worse. Not realizing that the patient's like, oh, well, I was outside. And you move on to the next. That should prompt another question. What were you doing outside? Well, I was in the garden. Okay. Were you doing physical activity? Were you stung by something? Was it really hot? And now we're thinking that this is kind of a heat-related injury. So this is where now it's a conversation between you and the patient. But this is a mnemonic to help you not forget any of the information that's going to be important. Onset, what were you doing? P, provokes or palliative. Does anything make it better or worse? It feels better when I sit down, it feels worse when I get up and move around. Quality, can you describe the pain? Can you describe the shortness of breath? So not everything is pain. So if your patient's complaining of shortness of breath, you don't want to say, so can you describe the pain? Like, not really any pain, kind of shortness of breath. And you're like, well, does the pain radiate? Like, no pain, shortness of breath. Shortness of breath doesn't really radiate anywhere. No one's ever been short of breath in their foot, right? So you want to tailor these questions to that chief complaint. Q, quality, can you describe that shortness of breath? Feels like I can't catch my breath. I have trouble getting air in. I have trouble getting air out. I feel like I get hit in the gut. If it is pain, that it feels, is it, does it come and go? Is it, hot, burning, searing pain? It's a dull ache. We always want the patient to try to describe it in their own words, and if we don't want to kind of tell them, well, is it a burning pain? Like, yeah, it's a burning pain. So we don't want to put words in their mouth. We want them, but if they're like, I don't know, it's kind of a pain. Well, does that pain, does it come and go, or is it all the time? We'll kind of give them some feedback and let them kind of now pick, so we get a better idea of how this is affecting them. R is for radiates. Does it go anywhere? So if it's pain, does the pain travel anywhere? If they have chest pain, does it go down their left arm? Does it go to their jaw? If it's shortness of breath, do you have pain or discomfort anywhere else? Maybe now this is an anaphylactic and they feel hot and itchy. So, is there anything else that's bothering you in addition to the shortness of breath? S is for severity. On a scale of 1 to 10, 1 being no, 10 being the worst ever, where do you fall? And then T is for time. How long has this been going on? Has this ever happened before? If so, what did they say? Okay? OPQRST, this is for our chief complaint. So the other mnemonic that we have in our history taking is our sample. Okay? S is going to be for our signs and symptoms. Remember, in talking in, our vital signs, sign is something that's outward and measurable. A symptom is something that the patient complains about, but I don't have any way of kind of measuring that. So nausea, a patient can tell me that they're nauseous. I don't have a way of measuring nausea. Vomit, I can see it, it's measurable, it's a quantity. So that's where now we're looking at signs and symptoms. So we talked about our OPQRST, we got the chief complaint. but that doesn't mean that that's the only thing going on with the patient. So we always want to make sure any other signs of something, anything else bothering you today, headache, dizziness, nausea, and we'll talk about kind of our pertinent negatives. A is for allergies. So we want to know if the patient has any allergies to any medications. So anything that they, especially have like an anaphylactic reaction to. So if it were to food, if it were to, something environmental, we still want to know that information, okay? Shellfish is an allergy a lot of people have, and it's really that they're allergic to the iodine. So there's a lot of medications and a lot of contrast dye that they use in the hospital contains iodine. So if the patient had a shellfish allergy, just because we're like, well, we're probably not going to get any lobster on the way to the hospital, you'll be okay. That's an important, part of their information. Antibiotics. So if we have a patient and they're going in for surgery, or if they, major trauma, they're likely going to get an antibiotic. So these are things we want to make sure that we're passing on to the hospital. Okay. M is for medications. So what medications are they on? Are they on, beta blockers to control their heart rate and their blood pressure? Are they on other types of cardiac meds? Are they on blood thinners? So if we have a trauma patient, they're on a blood thinner, we're concerned now about not being able to control this bleed. So we want to get a complete medication list. P is for past medical history. So anything significant. So we don't need to know about having their tonsils out when they were 4, but if they had their tonsils out last week and now they're having problems with that, that would be a pertinent part of their history. So we're looking for, do they have a history of high blood pressure, high cholesterol? Do they have any cardiac? Are they diabetic? Any history of strokes, major surgeries, hospitalizations in the last bit? Are they an asthmatic, COPD? We're looking for any part of their medical history that's going to be important for us. L is last oral intake. How long ago did they eat? And this is, a couple of different things. So one, we're looking at if they do need to go for surgery, the anesthesiologist who's going to put them under for surgery, they're going to prefer them not to have eaten in the last bit. If you go in for surgery and it's known, they tell you not to eat for at least 8 hours before you go for surgery, so you have an empty belly. So last oral intake. If it's the diabetic, when was the last time that they ate? Did they eat something significant? So now allergies. What was it that they ate? Is it potentially something that contained an allergen to them? Or is this now the first time they're having an anaphylactic event to some type of allergen? So this last oral intake. And then E is events leading up to this. So, what were you doing? What happened? Has anything like this happened before? Have you been hospitalized? Have you seen a doctor? If you did, what did they tell you? Were you diagnosed with anything? So sometimes you may have, they say, it feels like, the last time I had kidney stones. Okay, well, it's likely then, the same symptoms and they feel kind of the same way. It's likely that that's probably what it is. We're still going to do a full assessment, but now we're starting to kind of look to narrow down this path. When we show up, it could be anything. We're starting to now try to find some feasible things that make sense with what's going on for the patient. Okay? So as we talk more, we're going to see, age and underlying health conditions, patients who are diabetic, who have a metabolic derangement, they're going to have, anything that kind of trauma or injury, medical complaints, they're going to be more complicated because their bodies aren't going to respond the same way as a healthy individual. So now we're kind of looking at putting this all together. So as we start to kind of go through this is kind of to supplement, your information there, but this is just to kind of break this down into kind of simpler, ways to do this. If you kind of block this out when you're trying to, the only way you can get through assessment is you have to memorize it. You have to know it, you have to own it, and then over time, you start to, you see other people do things, you're like, oh wow, that was kind of cool, I like that, I'm gonna start doing that. That was a really kind of, slick way of asking that question without offending the patient. I'm gonna kind of word it that way. And then you're gonna see things that are terrible, like, oh my gosh, I'm never gonna do that. So you start to become the accumulation of all of the best practices that you've seen throughout your experience. So your assessment is kind of evolving. And you're gonna see that you're gonna have to adapt how you ask questions based on how old they are. I can't ask a 1-year-old the same questions I ask a 6-year-old or a 60-year-old. So you have to be able to adapt to the patient and where they're at, okay? Once we've gone through, we always try to get the information from the patient. There's certain things we always want to be able to document that we asked about. So we call them, this is where we have what we call pertinent negatives. So this is where we get to say we asked the patient but they denied. If we don't ask the patient, we can't put that the patient denied they had any pain if we didn't ask them about it. So when we start looking at kind of these pertinent negatives, and we write like kind of patient denies in our report, we're going to look at patient denies, we're going to start with any dizziness, headaches, ringing in the ears, any chest pain, shortness of breath, any nausea, vomiting, diarrhea, right? Any weakness in the legs, any other pain associated, anywhere in the body, anything else going on today. If now I can write patient denies, headaches, nausea, vomiting, diarrhea, chest pain, shortness of breath. I asked the patient and they said, no, I don't have it. If I don't ask the patient those questions, I cannot put that in here. I cannot document something I did not do. So this is where now, after I've gotten all the information, the patient has given me this information, I'm now going to ask very pointed questions. Do you have this? Do you have this? Do you have this? Do you have this? Any of these symptoms? If they say no, 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 patient denies. Like, well, yeah, actually I have felt a little bit nauseous. Now I want to ask some more questions about that. Well, have you had any vomiting? No, but I felt kind of nauseous. How long has that been going on? Right? So now this helps prompt us asking if there's other things that maybe are kind of escaping the patient's mind, or they don't see the two connected and being relevant. So this, when we put it all together, this is how you do a very thorough assessment. And we're going to see, as we progress in our medical emergencies and our trauma, everything becomes kind of a plug and play right back into this assessment. So we're going to see now that we want to kind of get these memorized in this module early on, because everything else is going to fluidly, we're going to look at these patients and start doing case studies and looking at, all right, here's the patient with this, exacerbation of COPD. Let's walk through our assessment. What do? We show up on scene, we get the call, we're going to start the scene survey, scene safety PSI. All right, we got one patient, they complain of some shortness of breath, we're starting to walk through our assessment. And that way we get good practice. So by the time we, kind of finish up, we're ready to go out and actually take care of people. Okay? So make sure you're looking at those sheets. If not, you've got this written down, and this becomes kind of that script for you. You're just going to memorize it. Primary assessment, find and treat life threats. Do that first. Everything else now, we start to come back. Every time we get back to the top, we reassess everything we've always done. If I have a patient where we're managing their ABCs, I may never get to this detailed assessment. And that's okay. Our job, remember, we need to know our role. Our role is to stabilize this patient, keep them alive, get them to the hospital where they can get definitive care. All right?